morning to everyone. I'm Ravina Murthy. I'm studying nutrition at Collateral at Korean Era. I'll be your moderator today for the webinar titled Approach to Elevated Liver Transaminases. First of all, let me extend a warm welcome to all of you on behalf of the organizing committees. Now, this webinar will be presented by our speaker, Dr. Chen Ting-Yu. Allow me to introduce Dr. Chen before we kick off with the presentation. Now, Dr. Chen is a Malaysian. He was born and bred in Malaysia. He is currently the principal GP at the Wellness House Medical Facility, the county Orange, in New South Wales, Australia. Now, he obtained his undergrad degree from Mangalore, India, in the year 1986. He then obtained his FRA GP in the year 1998. He also has several postgrad diplomas, including Diploma of STD, HIV, and also Diploma of Drug Med and Hygiene from Bangkok, Thailand. He has extensive learning and teaching experiences, around 22 years in India, Malaysia, and Thailand, and also around 20 years in Australia. His interest includes teaching and clinical care. He's also an examiner for the RACGP and the conjoined NAFB and RACGP. Now, without further ado, let us welcome Dr. Chen.
Hopefully I can, it's the first time we're doing it together from Malaysia. Okay, so this, I decided to write this up to, it's an approach to any sort of lab test. For that matter, in case as one doctor who actually said he went for exam, it was given some abnormal lab values to interpret, and then the approach to that, and also the same with our doctor and the GP as well. We have given sort of laboratory parameters to interpret. So I've written up this in a Socrates approach. So step one, and there are 8 steps. So basically it's a systemic analysis. So you basically have a rough idea of what's it all about. Always the onset, and then C, we can talk about causes. And as a GP, we learn most common to less common to rare. And R is for relatives and risk factors. And risk factors always includes smoking, nutrition, alcohol, physical and occupational thing. A is associates. So you must examine the patient symptoms. Even though you are given a lab parameter in the exams, if you fail the exam, if you don't examine the patient, you still need to ask. So T is for treatment. The treatment is always, it can be for the condition, it can induce the condition, it can be the cause of the condition as well. And before the COVID, obviously with travel, some travel diseases can be, sometimes you can get tuberculosis because of travel abroad as well. So it's important to ask for T as well. And normally sneak in investigations to go through it. E is expectation. So we go and ask the patient, is that what you expect? No? Is that what you want? Or just to, and then as we do a summary, and then probably we come to a conclusion. So this is a normal, so this is an example is given for any lab parameters that are given in the exam and in your practice. It's a Socrates approach, I call it. This is the normal sort of thing that you can see in the normal algorithm for liver function tests. So we normally have, like, if the liver enzymes are up, ALT, AST, then it is more of a hepatocellular damage. And synthetic means they made it, so it's the albumin and also the prothrombin time, INR. And then they got isolated, like Gilbert syndrome and cholestasis. So this is what the approach algorithm is. So we just concentrate on liver enzymes today and don't deviate from others. So we just say ALT, AST, and then basically the liver transaminases, which is the topic of today. Of course, there are other enzymes that you can't ignore, like alkaline phosphatase and GGT and nucleotides and lactate dehydrogenase. Systematic analysis means that you got to have a rough idea of what the parameters are telling you. So in this case, this is the liver functions. So this cholestasis, just bilirubin and GGT. ALP and GGT, transaminases ALT and AST, and synthetic is INR and albumin, basically. So this, yeah, basically telling you what. So these are the slides that you can go through it later on. So where does ALT come from? It comes from the liver, whereas AST is a bit confusing. It can come from other organs as well. And these are normal levels. So basically, when you look at liver enzymes, they always can be an isolated liver enzyme, which is usually doesn't happen, but it can happen, liver transaminases. Sometimes there's a mixed elevation with other cholestasis or synthesis dysfunction. That means there is a mixture of raised ALP and bilirubin and also INR and thrombocytopenia as well. Then the second important thing is the magnitude of it. So the magnitude tells us that whether it's less than, so you look at the upper limit of normal, and you must know the less than 15 times, and more than 15 times, we normally send it to the specialist, hepatologist. We try not to treat anything that's too high, treat liver transaminases. I would even go up to 3 to 5 and even. I would normally comfortable to treat liver transaminases 3 to 5 times the upper limit of normal. And there's hepatic cause and non-hepatic cause. And these are the non-hepatic cause. Non-hepatic means don't blame anything on the liver, because there's other things like the MI or adrenal insufficiency, thyroid, celiac disease. And then there's a condition called heart failure. We call it congestive hepatopathy, right-sided heart failure. And these all can cause less than 50 times upper limit of normal. Adrenal insufficiency is so it comes up in the exam as well, FRSCGP exam in Australia. So they are expected to know it by heart as well. No? So weakness, and you have to do the syntactin test and all that. You can know it by heart. Serum cortisol is less than 200, then you do the synectin test, you inject synectin an hour, 2 hours, then it's more than 500 is significant. So it's endocrinologist stuff, but then in the FRCB exam in Australia, it comes up as well. And usually comes with generalized weakness. So it can be a cause of non-hepatic. And I put in the table, the next one is...
Dr. Tim, I'm so sorry again. Because the slide is on our end, it's not moving. Is it
not moving here. Yeah. So I should move from here, isn't it?
Yeah. Can you just click one time?
Oh,
yes.
Okay. All right. So sorry. So I click here on this screen, and so these are the ALT, AST, which I talked about, organs, and then AST is on the other organs as well. And these are normal values. And then I said about systemic analysis. So we look at it as whether it's an isolated or a mixed elevation, and the magnitude of it, which I said I would treat anything between 3 to 5 times upper limit of normal. But I'm not happy with treating anything above 6 times. But this one is a bit exaggerated, 15 times. But the causes can be a liver cause as well as a non-hepatic cause. So these are the ones that I spoke a bit about adrenal insufficiency earlier, and these can be one of the causes of non-hepatic causes of upper limit normal. Okay, so this is the table that's summarized everything. So now less than 15 times is the most common, and AST, you see the ratio, AST more than ALT. The most common is alcoholic, and less common is cirrhosis. So somehow rather in cirrhosis, the AST comes up. Whenever there's a cirrhosis, AST to ALT is more than 1, more than or equal to 1. AST, ALT less than 1. Now, what is NAFLD? So this is replacing NAFLD now. So it's metabolic association, functional fatty liver disease. So it's a metabolic dysfunction now. And it's a very interesting topic, which I thought. So is the non-alcoholic liver disease is now, fatty liver disease is now been phased out. We don't talk about it anymore. And this NAFLD is most common because it's a global, I guess it's a sort of epidemic now with obesity. People get fat and good life. The liver gets fatty liver as well. Then less common is easy to remember, So the most common cause is either NAFLD, or the old name is NAFLD, and alcoholic liver disease. Less common, easy to remember, the 3 H's. See that? Hepatitis, herbal, and drugs and occupational. And in Australia, of course, hemochromatosis, but in Malaysia might be different. So 3H for less common, 2A's for rare ones, autoimmune and antitrypsin deficiency. So remember, the most common cause is NAFLD and alcohol with a different ratio. AST, ALT less than 1 in NAFLD and more than 1 in alcoholic liver. And less common is the 3 H's in Australia. And then the 2A's are this. And so this is one illness, Wilson, very rare. I haven't seen it in my 36 years of practice, but it's a hepatic cause where the ratio can either be less or be more than 1. So it's a mixed thing. And these are causes of mild transaminases. This one all you can read up later. So step 1 is basically analyzing the liver transaminases elevation. And you got to have a rough idea. So you got to know is it an isolated? Is it associated with other liver enzyme increase? And also you got to know about the magnitude of it, which either to touch or not to touch. If too high, we don't touch them. Okay, and then the ratio, whether it's AST, ALT raised, in which you think of alcohol and cirrhosis, or ALT, AST less than or equal to 1, where they got the, again, common, less common, and rare causes. Less common is always the 3H. Then step 2 is the onset. So Socrates, first system analysis, always the onset. Onset is easy. Anything less than 6 weeks is acute. So some patients, they don't even know, hey, have you got liver enzymes raised? Say, oh, probably I did it like 2 years ago, you know. And then you say, well, bring back your results, we analyze the thing. And I'll tell you the significance later, why it's important to analyze the whole picture of it. So anyway, chronic and 6 is acute, chronic, and 6 months, more than 6 months is chronic, which is like for Hep B and Hep C. So these are the causes of chronic liver disease, CLD in Australia. Okay, so I have a format in my surgery. This is my own format. I made it besides the day that my patients come. I always check metabolic syndrome. So I always ask metabolic because they are common. Whenever I see, I do the waist circumference, I do the blood pressure, diabetes, and if they are big size, I do HDL, I mean the lipid profile, triglyceride. So I actually rule out NAFLD. And then common things occur commonly. So I do alcohol as well. Ask an alcohol history, which can get an audit C score, and look at the AST, ALT. Then I look for the 3 H's. I look for herbal and drugs. Sometimes mushroom pickers, occupational can get. So the herbs means everything. The other H is for hepatitis, B and C. And the third H is hemochromatosis. We don't use ferritin to check, because ferritin is not accurate because they are acute phase reactant. So we use a transferring saturation. So this is the format I devised for my, not perfect, but still, we're basically looking at the most common cause and the least common, but not looking at rare ones. But we have picked up rare ones before. And these things you can read up about it. You see that? Translated more than 45%. And those who come to Australia to practice must know a little bit about hereditary hemochromatosis. These are the other things that you can read up. So this is came out in the September 2021 Australian Journal of Family Practice. So now it's opened up eyes of everyone. So no more non-alcoholic. Now we talk about this. So anyone with diabetic, anyone who's overweight, including me, overweight and obese, and so the BMI, see, for us Asians is 23, for Caucasians is 25. So don't be happy if you don't have a BMI of 23. You're still considered as overweight, obese. And then you can look at out of it, or you can have 2 out of 7. 2 out of 7 includes so waist circumference. So 102/88. Women is 90/80. sorry, 102 is for the Caucasian men and 88 for women. 90/80 is for us Asian men and Asian women. So the waist circumference is always trying to match it between the rib, the lowest rib, and the hip there. And you got to actually, somewhere around the umbilicus, I got to measure with expiration. I think we all will fail with circumference. If we score mostly 1 point there. Blood pressure more than 130/85, which is like stage 1 hypertension, which I talked about in the first lecture. Triglycerides are also used as well. HDL is less than 1 in males, and less than 1.3. And this is hardly used. It's called HOMA, HOMA, homeostasis assessment of insulin resistance. And plasma high sensitivity C-reactive protein more than 2. So you've got all this, any of these, you should go for liver ultrasound. Because liver ultrasound is the one that changed the diagnosis of this metabolic associated fatty liver disease. And I think there is lots of us, I think it's about a quarter of the population has got metabolic associated fatty liver disease. So these are my summary. So this is like the old format, non-alcohol. Just say, oh, if you in Australia say that if you don't drink more than 3, the standard drink for men is 3, female is 1 standard drink a day. But if now the NAFLD, they extend it up to 3 and 2, and then you have the what I summarized earlier, overweight, obesity, type 2 diabetic, 2 out of 7. So you should know this by heart. This has been phased out already. So forget about NAFLD. We concentrate on this. And so this is the percentage in Australia, but this slide is very old slide, about 10 years ago. It's probably gone up by now. So these are the risk factors which you can read about it. So disease association with MFLD, the mnemonics is CHOPS gut. So basically, is this association. So some patients have hyperuricemia. We don't understand why uric acid is high in MFLD. And you can see PCOS is involved as well, sleep apnea. So I find it very fascinating because it brings together so many diseases together. And it's my interest as a family physician to look at all these things and put them all together in one map. And I really like this metabolic dysfunction. So all you have to do for alcohol is just ask 3 questions. How often do you have a drink? How many drinks? How often do you have 6 or more? And then you score them. See that? History. So this gives you a questionnaire. So that's alcohol done. So alcohol is and MFLD are the 2 common causes of fatty liver disease. I talk a bit about the 3 H's, the less common. So in Malaysia, we have a lot of Hep B. In Australia, this is a map. So you see that the migrant population and the indigenous contribute nearly about 50% of hepatitis B. So Southeast Asians, that's us, 33%, and 16%. The Caucasian men, hardly anything. They're either one of these. So we basically occupy nearly about 60–70% of we contribute to the hepatitis B burden. And I always tell my patients when they check Hep B, so I like this, when you do a hepatitis B, so when you're infected with hepatitis B, your B surface antigen comes up and then drops at 24. And there's a window period between 24 and 32 where you can't pick up Hep B surface antigen and you don't have surface antibody as well. So 4, 24, and 32 are important figures to remember. Between 24 and 32 weeks of the HPV infection, you get both negative. So it can come out as a negative as well, unless you do the total anti-HPC. But of course, in Malaysia, we keep on doing tests. It adds on more money for the patient, unless you're in public service. So there are important figures to remember, 24 and 32. And these are, so the risk of, they get cirrhosis, they get HPC, hepatocellular carcinoma. And we normally try to, in Australia, we try to classify them into 4 phases: tolerance, clearance, control, and escape. So GPs monitor, in Australia, monitor all this every 6 months. We do an ultrasound, we do alpha fetoprotein. In Australia, you are not allowed to prescribe antivirals HPV unless you go through a training course, which will be about 3-4 weeks ago. So until now, I still don't prescribe, but I do follow them up. You're supposed to know and pick up. So 2 and 4 are supposed to be the bad things. The even numbers are bad. So 2 and 4, you need to refer to specialist liver. 1 and 3, you monitor every 12 months. I think for malignancy, you do 6 months, but this one is 12 months. So malignancy means just LFT, ultrasound, and AFP. But in this case, it's every 12 months. For this HBE, HBE or DNA, viral load and liver function test every 12 months. So this 1 and 3 are good numbers, 2 and 4 are bad numbers for HBE. And this is basically the same thing that we're talking about. So clearance and escape are bad phases which you need to refer. These are, so when to refer is the immune clearance or escape, 2 and 4, phase 2, phase 4. If your HBV DNA is more than 104 copies, suspicion of liver disease, and those with decompensation. Okay, Hep C. So Hep C is also common. Hep C, I think it's the most common blood-borne infection in the world. So Hep C, more than 130,000 Australians. But in GP in Australia, you're supposed to prescribe this Hep C, So you must know how to prescribe. It comes out in the exam as well. I remember I taught my registrars, I think 3 of them went for exam. And one station came out in the OSCE with a Hep C. They are supposed to treat Hep C. So unlike Malaysia, we don't, we give them to specialists, but here in Australia, we treat them. Hep C, GPs can treat Hep C, but not Hep B. And these are the comorbidities that can affect the treatment consideration. These are for us, naive means first timer, we treat them. Now, when we have 12 weeks, now we reduce it to 8 weeks already. Cirrhosis, I normally refer to the specialist, or you can correspond with the specialist. They can guide you on the internet. They can tell you, I got a friendly gastro here, so he corresponds with me and tells me where to go. And after you build up some confidence, you can do your own prescribing. Okay. So special populations, you got to refer. Can you see this? Special populations for livers. So you have to refer. Can all of you see the slide now?
Yes.
The special population is for liver Hep C. So again, anyone with Hep B, Hep C, you refer. Together, if they have a concurrent Hep B infection, you refer. So this is the problem with Australia. It's about nearly 6 million people in Australia with chronic liver disease. And it's going to increase to 8 million in 2030. So basically, these are the slides, repetition of the slides. And I'm going to talk, so we talk about the herbal and drug later, but this is autoimmune, which I diagnosed in one patient, very rare. She came with cirrhosis, but I use this criteria, a point system, but I still need a liver biopsy, which is very painful. I diagnosed that she has autoimmune liver disease. Okay, now, so step 1 is system analysis. Step 2 is the onset. Step 3 is the cause. C. So the causes can be most common, less common, and rare. R is relative hemochromatosis. Hemochromatosis you got to know in Australia if you're coming to practice here. So it's about 250 to 300 white population. Carrier is about 1 in 10. So they use the transferrin saturation because this one is not accurate, serum ferritin. And so it doesn't mean that your hemochromatosis gene, you're bad. So this one came in the Czech magazine. And I find this one very, very, I think this table came out in 2019, the Czech magazine. So only when you are, some people get worried because they got H63D, but H63D is supposed to be a good one. Especially the heterozygous, we don't even bother to get them worry about venesection. when I first came from Malaysia to practice here, I find it difficult to guide like hemochromatosis because I never see them in Paribunta or Materet in Malaysia. So I find a lot of problem when I first started this. But now, of course, we get used to it. So we normally worry if it's homozygous 282Y or compound heterozygous. Then there's a guidelines here that tells you what to do. So these three is you don't bother about it. It normally starts problem at 40, like 40 years of age. For the females, especially because they menstruate, so the problem of hemochromatosis is only seen at the age of 40. These are the sort of algorithm for liver biopsy. So, and then you ask for, so after that you ask for symptoms and signs, which you all know. So SOCR, A is associated symptom. Again, this is symptoms that can occur with cirrhosis. And also, the signs with cirrhosis, I'm not racist, but I use it to this mnemonicus. Japanese or Chinese also, or Koreans, they're all yellow. So I said, oh, yellow, we use JAPS, J-A-P-S. So J for jaundice, A for asterixis. Then P starting from the head to toe. Always remember things when I start from head to toe. Parotid gland enlargement. Then you smell them, they're smelly from the oral cavity. Then we try to palpate the breast tissue. About 10% palpable tissue is gynecomastia. And P for also palmar erythema. And then with other associated liver, upper limb as well. And then portal hypertension. And portal hypertension signs and portal hypertension complication. And S for spider nevi. So JEPS is a mnemonic used to suggestive of cirrhosis, which you can apply when you look at patients and under clinical finding. That's spider nevi, but it's very specific. One of the most specific signs for cirrhosis of liver. And this is the mucous nail, where you can see the white bands, parallel white bands, and then proximally there's normal, but then you can see parallel lines running across the nail. Teres nails is different. For teres nails, this proximal portion is white again. Distal is brown. So this one can come up in your exam as well for KFP. And nowadays exams are getting more difficult. They ask you things that they expect from they think that we are all specialists. GP is a family medicine specialist. So sometimes they can go from can go to a normal specialist level as well. So treatment and investigations, we go to treatment. So I'll just give you a few examples. So treatment, drugs can cause treatment. So I just give you an example. If you can just find out the drug, the spectrum, and the side effect, then you can sort of more or less work it out, like beta-dopa, labetalol, amiodarone. Amiodarone is another favorite question for the exam because it can cause thyroid issues. It can cause the bluish like pigmentation. Amiodarone seems to be a common multiple choice question or KFP for the exam because it's got multiple features. And then lipid lowering drugs, statins as well. So you can read up about this. So, and then the main thing is the patient. So it doesn't mean that when you have liver parameters, you stop at that. But we need to ask, we need to examine the patient symptoms and signs. At once fibrosis. So the fibrosis, see that the progression of fibrosis to cirrhosis, and then in hepatocellular carcinoma. So this is a very old slide, NAFLD, then becomes NASH. Once NASH is fibrotic, so this is that they can proceed to. And in my last study, you will find one of my patients actually has hepatocellular carcinoma. He has cirrhosis, and then he developed hepatocellular carcinoma. These are things you can do as a primary care physician on your phone. So you can use an APRI score, a FIP4 or NAFLD. So it's something you don't even have to use, don't have to pay money. Just go in. This only few parameters: AST divided by upper limit of normal, divided by platelet count, multiplied by 100. Gives you an APRI score. again, to calculate fibrosis. FIB4, you can see the value, 1.3. So what do you do? So these are guidelines to tell you whether the patient has got advanced fibrosis or not. This is the NFLD score, which is the whether to refer for fibroscan or not. And this is a comparison between NFS and FIB4. FIB4 apparently, I use a lot of FIB4 to compare. And these are the other things that we look at: the platelet count, the sodium, and okay. Then, yeah, so these are again repetition of everything, but we're talking about investigation.
Now, okay. Can you just test? Yeah. Okay, good.
Okay, so these are all the liver ultrasound you can do, and you can read about it. And the stage of fibrosis and pre-cirrhosis and cirrhosis. And they proceed at 0.12 stages per year. So you're looking at, like, if your fibrosis progression about, say, proceed from stage 0, say stage 2 to stage 3, is 0.12 stages per year. So probably in 10 years, it might proceed up to 1.2, 1.2. So it probably takes about 9 years or 8 years to proceed to that. And this is histology that will show up if you have this is the old histology that shows that, of course, you have type 4, there's bigger chance of getting it. And then after all this, so step 1 is basically, and this is standardized, it's just systematic analysis of the whole picture. Because they have idea what's going on, but you roughly know, depending on the magnitude and the ratio, and also the common, and then we move on from the common, the less common, and the rare ones. Stage 2 is onset, so you must know either acute or chronic. Stage 3 are the causes that you think of. What are the causes, possibly, and then complication. Stage 4R is any family history, relatives with it, and risk factors. Then step 5 is where you examine the patient, go back to just ask the symptoms again and the signs. And then T is the treatment. Treatment can be an induced treatment, or treatment can be treatment for the condition. And then we go to expectation. So we always, when we finish the consult, we always ask the patient, he said, what do you want? Do you want me to, I don't know what else you want, Sometimes they come here, second opinion, they ask me, because we all doctors with white hair, they come and ask us this, and then they say, am I having this? Is it true? So basically, is that, so, and the management part, I guess, and then rule out the red flags and also the prognosis as well. So these are the how you monitor. So this can come in the exam as well. How you monitor the patient without fibrosis. So after FIB1, what do you do? If without fibrosis, how frequent do you do it? And then monitoring the cirrhosis in Australia is 6 monthly at HCC as well. So once you're cirrhotic, and then once you got a platelet count less than 150, then you got to go for endoscopy. And the management is basically comes back to weight loss. And exercise is important as well. And then remove medications that cause it. So basically these are the, it's going to be just MAF-LD, just concentrate on MAF-LD in practical terms, because that's what the bread and butter of general practice is obesity. And this can be used as a prognosis, whether the patient needs liver transplant. You can calculate the patient, whether whether he's class A, class B, or class C. Because the patient wants to know about his prognosis, whether he should go to liver transplantation. And MELD tells you about the surgical, whether surgery is needed or not. I think it's the same thing. Okay. And hepatocellular carcinoma is 90% in pre-cirrhotic cirrhosis. And you screen them. So summary is important. So this is a case study, a real study. So one of my patients is like 53 years old. He's type 2 diabetic in 1996. So I think he first saw me when I had my surgery in 2008, and I saw him, and his HbA1c is very poorly controlled. I started him on insulin, I remember, and then later on there's no diabetic complication, just that his HbA1c, we brought it down to 7 to 8%. How do you convert HbA1c to fasting sugar? You multiply by 2 and minus 6. So your HbA1c is 8 times 2 is 16. 16 minus 6 is 10. So most patients are confused between HbA1c and fasting and sugar, because the sugar is the BGL, blood glucose, is what they measure at home, but HbA1c is what is measured in the laboratory. So they're confused. And you tell them is 10%. They say, yeah, it's not bad. They say 10% is what I get in my home as well. You got to multiply 2 minus 6 and tell them this is your 8-week control, 6 to 8-week control. That's your day, that's their 24-hour control. So that's different. Anyway, this guy, he went on and he was overweight in 2013, but he went and played hockey, very well controlled, and then metformin caused vomiting, so he lost about 35 kilos. And then dietary, medication, everything went down to like further reduction. So he lost about 45 kilos. Ceased smoking, 30 years, sometimes drinks a bit of alcohol, just like, most of us are. Endoscopy, 3 years, picked up some varices. Otherwise, he's asymptomatic. So this is current BMI, 170. BMI is 31.9. His vital signs are normal. But when I examined him, I saw spider nevi and no other issues of cirrhosis. Then his liver enzymes are pretty interesting, but you can see that the AST is climbing up above ALT. Again, what I said, the ratio was, there's an indication that there is a cirrhosis. And we, of course, as a completion sake, we do Hep B, Hep C, although they are rare. We do iron to rule out hemochromatosis. We do, and it's normal AFP. And celiac disease also we did. And really, ultrasound, we found 2 lesions. And actually, he had hepatocellular carcinoma. He developed HCC. And it's difficult to pick up because his weight loss, sometimes his weight loss because it's intentional weight loss. But you measure the FIB4, see that? I did measure the FIB4 from time to time. So I'm a bit obsessive with this one. So when you climb up to here, see that? This is when they turn, it's a malignant. I mean, yeah, looking back, I don't know whether I could have done anything more for him or not. But anyway, we could see that the FIB score. So the FIB score is very important. As a GP, you must do FIB4 because this one, it doesn't cost the patient any money. You just plug in the figures and put the values, and you can get the FIB4 result. And basically, yeah, that's it. So basically, it's a very short talk, but it's we talk about. We wanted you to have an idea of how to approach an abnormal laboratory parameter, but you must have a rough idea, and there are 8 steps to do it. So analyzing, again, to summarize, the systematic analysis, step 1, then the onset, which is the acute or chronic. Then you must know certain causes, because once you got the analysis abnormal result, you must have an idea what are the causes, what are the causes. And these causes is divided into 3, depending on the ratio and the magnitude. And then in terms of common, the R is relatives. Family history is always important. Always ask family history. In most of my registrars, hey, why no family history? They forget to take family history. Then A is associated symptoms and signs, which goes back to basic primary school, clinical science, medical school science. Then T is treatment. Always ask for treatment. So treatment for the condition, but treatment sometimes can be a cause of the condition. And then after, and the investigations that are done. Then after that, I sit back and ask them about their expectations. What do you expect? I said, why do you come here in the first place? You know, they totally told them. In this case, that patient is my patient all along. So he basically wants me. He's just following up with me regarding this. And in a multiple practice, sometimes it's difficult because sometimes they don't see you. Like our practice, about 7 doctors here. Sometimes he doesn't see me, he see other doctors. So again, there is a loss of follow-up as well. And then you summarize the whole condition, and then so you can use this approach for anything. So I can throw you a result of abnormal renal function and see how you approach it, or another abnormal full blood count, say lymphopenia or lymphocytosis. And asking you to approach. I think the approach, this is my approach. It may not be the best one, but it's something to share with you all. Is there anything else? So actually, I finished this short talk today, but anything else you want to ask?